Another interesting one from Professor James Shambrook. He is the consultant radiologist at University Hospital Southampton, UK, and he is the current president of British Society of Cardiac Imaging and British Society of Cardiovascular CT. Now, past president to present president. Over to James.
Well, hello, and thank you very much to the Sri Lankan College of Cardiology for inviting me to give this talk on the application of CMR to practice. It's a huge honour, and I'm hugely disappointed I haven't been able to give this talk to you directly in Sri Lanka itself. But nonetheless, here we are, and I'm pleased to be able to talk to you today. I just want to explain a little bit about myself. My name is James Shambrook. I'm a consultant cardiothoracic radiologist at the University Hospital in Southampton in the United Kingdom. And we are a dedicated cardiothoracic imaging unit. We have our own 1.5 Tesla CMR scanner. We've got a dedicated cardiac scanner. And this is the makeup of our unit. We're 7 consultant radiologists. We have an adult cardiologist, 2 pediatric cardiologists, and we have radiology and cardiology fellows, as well as our normal trainees, and 8 specialist CMR radiographers. So we're a reasonable size unit, and we're doing in the region of 2,600 to 3,000 cardiac MRIs a year. The unit's been established since about 2006, and I started working there in 2009. Well, the brief I've been given today is the application of CMR to practice. As I'm sure many of you are aware, this is a huge topic, and one that I'm going to struggle to cover all of it in 25 minutes. So I wanted to break it down a little bit and really talk about 4 key areas that I think are most relevant to my personal practice. And that's 1, looking at chest pain imaging, then looking at structural heart disease, talking a little bit about myocardial inflammation, which has been very topical in view of the recent pandemic, and also just touching, but only, I'm afraid, only a small touch on congenital heart diseases. That is an area of interest of mine as well. I think the real beauty of cardiac MRI is the fact that it is truly multi-parametric imaging. We get to look at a whole range of different aspects of the heart, looking at anatomy. We're able to quantify function of both left and right ventricle, as well as atria if needed. We're able to look at tissue characterization. We can see whether there's any scarring within the heart, or indeed we can actually look for specific features of edema or diffuse fibrosis with some parametric mapping techniques, which I'll talk about a little bit later on. And we're also able to quantify flow, something that, as I'll touch on later on as well, is really important, particularly in the congenital population. But I'd like to start with a case, if I may, because this is talking about CMR in practice. And this is a patient who is an 83-year-old woman, and she presented with chest pain and shortness of breath. Now, this study was done a while ago, and so the investigation of choice initially after an echo was to perform an angiogram, because there was genuine concern that this was angina. And here, hopefully, you can see a selection of her angiographic pictures, including her LV gram. And I think you'll all agree there is quite extensive diffuse 3-vessel coronary artery disease and impairment of left ventricular systolic function. It's not clear at all if any one of these lesions is responsible for her recent onset of chest pain. And as a consequence of these findings, the angiogram was completed with no stent inserted, and the cardiologist requested the patient to have a cardiac MRI to try and understand a little bit more about the nature of a coronary artery disease and whether there'd been an acute coronary event or whether indeed she had any evidence of myocardial ischemia. And so, as part of our assessment of these patients who were referred for cardiac MRI for query myocardial ischemia, there are 3 key questions that we ask. One is, what is the ventricular function, particularly the left ventricular function? We then look to see if there's any perfusion abnormality at myocardial stress, and then we're looking to see if there's any myocardial scar. And here you can see a selection of 6 cine images of the 4-chamber, 3-chamber, and 2-chamber long-axis views, as well as a basal, mid, and short-axis cine imaging. I think you'll all agree that there is clearly impairment of left ventricular systolic function, but this appears to be fairly global. There's no wall thinning and no obvious focal wall motion abnormality. There appears to be some dilatation of the mitral valve annulus, and there is some associated mitral regurgitation that we can see here. One of the real advantages of cardiac MRI is we're able to quantify ventricular volumes absolutely by contouring the myocardium at all the different levels. And on doing that, you can see here we're able to generate a left ventricular volume curve. And in this particular instance, this tells us that the patient had a left ventricular ejection fraction of 26%, so severe impairment of left ventricular systolic function. We'll move on now to our perfusion sequence. And we've got two sets of images here, a stress perfusion and a rest perfusion sequence. To generate our stress perfusion images, we administer adenosine for 3 minutes via an intravenous infusion to the patient while they're lying in the scanner. And the adenosine will cause dilatation of the capillary bed within the myocardium. And what we're looking to do is create myocardial hyperemia. And once we've created that state, we'll then give an injection of gadolinium, the contrast agent we use in MRI, to see how well the myocardium perfuses on the first pass perfusion technique. We then will let the patient recover and wait 10 minutes or so while we do some other imaging, and we'll come back and do exactly the same set of images but without the adenosine, so so-called rest perfusion. And then we look at these two sets of images to see if we can compare the difference. And I hope all of you can agree, as you've been looking at this, there is clearly a subendocardial perfusion defect here within the basal inferior septum and inferior wall, here at mid-chamber level all the way through the septum and extending onto the inferior wall, and down here at the apex again throughout the septum and onto the inferior wall. So quite an extensive subendocardial perfusion defect, which is not so readily prevalent on the rest imaging, suggestive of concerning for potential upstream epicardial stenosis within the coronary arteries providing these territories. And then the final set of images that we take on any chest pain assessment is something called late gadolinium enhancement sequences. Now, for those of you who don't know, late gadolinium enhancement works because when we give gadolinium to a normal individual, the gadolinium will wash in and wash out of the myocardium within about 10 minutes or so. However, if there's any evidence of focal fibrosis, such as there's expansion of the extracellular volume, or indeed if there's any evidence of acute myocardial injury such that the contrast agent, which is normally purely in the extracellular space, can leach into the intracellular space, we'll see gadolinium hanging around, indicating areas of focal scarring or myocardial damage. Now, those of you who've seen these images before will hopefully agree with me that there's really no significant late gadolinium enhancement to be seen here. I believe this is artifact here in the anterior wall, throughout the myocardium. I'd just like to put up this comparison images here on the right-hand side, and this is an example of subendocardial late gadolinium enhancement in a patient who's previously had an LAD territory myocardial infarction. And you can see we're seeing no evidence of this. So the important thing to say here is this patient has no focal myocardial scarring, no evidence of previous myocardial infarction, but they do have impaired left ventricular systolic function, and they have an extensive inducible perfusion defect, which was felt to be secondary to the disease we saw in the LAD and right coronary artery. And this patient was referred on for coronary revascularization on the basis of having viable, non-infarcted myocardium, but clear evidence of myocardial ischemia on these studies. So that was an example case of what we do to use cardiac MRI for chest pain imaging. But I just want to draw your attention to the guidelines that we use in the United Kingdom for those patients who present with new onset chest pain. And we use the NICE guidelines, and these were updated in 2016. And in the United Kingdom now, the advice is for anyone who can't have angina excluded by clinical assessment alone, cardiac CT is recommended, and my colleague Dr. Bull has talked about cardiac CT already. However, for those patients who've got confirmed coronary artery disease, then non-invasive functional testing such as stress perfusion MRI is an indicated source, and that was the case in this situation. Many of you will be aware that there are some very recent guidelines that come out of the American Heart Association and American College of Cardiology, again looking at both acute and stable chest pain assessment. And what they said in those patients with stable chest pain, that if you have an intermediate to high risk of myocardial ischemia, or coronary artery disease I should say, that anatomic or functional testing is an acceptable use. And for functional testing, this could either be exercise tolerance test, stress echo, SPECT, PET myocardial perfusion, or stress CMR, which they particularly say is very good for assessing flow, looking at LV dysfunction and scar, as well as looking at using pharmacological stress agents such as the adenosine we used in our case. They do go on to note that if the patients have got a younger and have a lower likelihood of obstructive coronary artery disease, then CT should be favoured. However, if they're older with a more likely to have obstructive coronary artery disease, they would favour stress testing. This is just a really lovely summary slide produced by the Society of Cardiovascular MRI, looking at what the American Heart Association said about CMR in these guidelines, and they've said effectively that in those patients, in stable chest pain patients, those patients with no known coronary artery disease, CTCA should be recommended, and that CMR is perhaps a secondary investigation and comparable to the other exercise tests. But for all patients with obstructive coronary artery disease, previous CABG, non-obstructive coronary artery disease, or suspicion of microvascular dysfunction, then CMR is comparable to all of the other stress perfusion tests that are being used. Just a little bit of evidence base behind the role of CMR in the investigation of chest pain. Now, this was a landmark study published in the New England Journal of Medicine in 2020. Many of you will be aware, the ischemia trial, where they enrolled 8,518 patients who had objective evidence of either moderate or severe ischemia on a non-invasive test. They were able to bring 5,179 patients into the study, and they were randomized to either angiography and revascularization when feasible, plus medical therapy, or medical therapy alone. And what they were able to demonstrate, as you can see on these charts on the right-hand side, is that despite patients all being admitted with moderate or severe ischemia on a non-invasive test, there was no difference in outcomes, whether that was death from any cause, myocardial infarction, or the primary composite outcome of major adverse coronary events, suggesting that actually the new secondary preventative therapy is equally effective at reducing death and primary composite outcome than angioplasty and PCI. However, subsequent investigation did show that there was evidence base for stent insertion and PCI as a very successful tool for reducing angina. And this is particularly noticeable in those patients who had a high burden of angina, as demonstrated on these slides here. First of all, if you had a score of 0, you had a very high burden of angina, which reduced very well if you were given PCI over standard therapy, and that's demonstrated here. So although there was no difference in outcomes, there was a significant improvement in angina-related symptoms with those who had PCI directed by the non-invasive functional tests. And one final piece of research that is been talked about a lot in the last couple of years with regard to cardiac MRI in patients with chest pain is the MR-Informed study that was published in the New England Journal of Medicine in 2019 by Ikenagel and colleagues, where they looked at patients who had angina and cardiovascular risk factors, and they compared MR-driven MR perfusion test-driven revascularization versus invasive assessment of fractional flow reserve, as indicated by the FAME studies. And what they can show here in this this figure here, that there was no difference between the FFR-driven intervention group or the cardiovascular MRI group, showing that CMR worked as effectively as invasive FFR assessment for determining who should go on to have revascularization therapy with no change in outcomes. So I'd like to change tack a little bit now and actually talk about those patients who have structural heart disease and where CMR has a role to play. And again, I'd like to start with a case. This is a 57-year-old man. He presented with left ventricular hypertrophy, identified it on his echocardiogram. And hopefully you'll all agree on these cine images here, there is some myocardial dysfunction, but certainly a degree of asymmetric left ventricular hypertrophy, with particularly the septum and the lateral wall appearing thickened. Well, we went on to do the late gadolinium enhanced sequence images, and I can highlight to you here there is an area of late gadolinium enhancement within the myocardium, but unlike the subendocardial hyperenhancement we saw previously, suggestive of myocardial infarction, this is within the mid-wall of the basal infralateral myocardium, and therefore a non-ischemic pattern. And there's really very little else to be seen elsewhere. And this brings us to talk about the different patterns of late gadolinium enhancement that we can see in patients. And this is an example of the descriptor of the types of late gadolinium enhancement we can see in patients in this article published in Circulation Cardiovascular Imaging back in 2014. And they describe these 6 types. The subendocardial type, that's very consistent with myocardial ischemia. And then these 5 other non-ischemic types, the so-called enhancement of the RV insertion point, a mid-wall stripe within the interventricular septum, subepicardial hyperenhancement, patchy mid-wall enhancement here or a diffuse abnormality. And I'd just like you to take a look at these examples here of cases that we've done in our institution of, well, on the left panel and the mid panel are the cine images, the left the four-chamber view and the short axis, and the right panel is the late gadolinium enhancement. And you can see here in this case, we've got a grossly dilated left ventricle. And when we look at the, with very poor function, when we look at the late gadolinium enhanced image, hope you'll all agree that there is this linear mid-wall stripe of late gadolinium within the interventricular septum. And this is compatible with a diagnosis of a non-ischemic dilated cardiomyopathy. If we look at this panel on the right-hand side, at the top here, much a better improved function, but perhaps mildly globally impaired. But we have quite extensive subepicardial late gadolinium enhancement, particularly within the basal anterior and anteroseptal wall, and to a lesser extent here within the basal inferior septum. And this was consistent with the patient who had known myocardial sarcoidosis. Down here on the left-hand side, we've got a patient with reasonable function but clear asymmetric left ventricular hypertrophy, although no evidence of outflow tract obstruction or systolic anterior motion of the mitral valve. But hopefully I can convince you all that there is clear evidence here of hyperenhancement within the insertion point where the RV inserts into the left ventricular myocardium superiorly and inferiorly, and this is consistent with a patient who has hypertrophic cardiomyopathy. And then the final panel here, again, of abnormal late gadolinium enhancement in this patient who's got left ventricular dysfunction, some circumferential hypertrophy, and clear gross biatrial dilatation with a shallow pericardial effusion. And when we look at the late gadolinium enhanced sequences here, you can see there is diffuse abnormality, almost circumferential subendocardial and mid-wall hyperenhancement, certainly in a non-ischemic pattern. And this is a fairly classic pattern of myocardial amyloidosis. Now I show you these examples just to show that the patterns of late gadolinium enhancement we see are really very good tools for helping us try and understand the etiology of some of the non-ischemic cardiomyopathies that we deal with. But I'd like to bring you back to the case that I discussed at the beginning of this patient who had this mid-wall late gadolinium enhancement within the basal infralateral wall. Well, one other tissue characterization sequence that we've been using over the last few years is something called parametric mapping. I'm not going to go into the details of the physics, but actually there are certain features of tissue that can be characterized within MRI, so-called T1 relaxation time, T2 relaxation time, T2 star, and assessment of extracellular volume. And T1 relaxation time can be measured on a pixel by pixel level and then displayed in a map, as you can see here. And what that means is then we can put regions of interest within the myocardium and actually measure the T1 relaxation time. And we know that this varies depending on disease state. And in this particular instance, I appreciate you'll have to take my word for it, with a T1 relaxation time of 919 milliseconds, this is uniformly low throughout the myocardium, suggestive of diffuse myocardial lipid deposition. And this was consistent with this patient's diagnosis of Fabry's disease. So in addition to the late gadolinium enhancement, we now have a newer tool of parametric measuring of T1 relaxation time directly to help us guide towards a diagnosis. And this has been a huge area of research within cardiac MRI, particularly in structural heart disease over the last few years, such that the Society of Cardiovascular MRI and the European Association of Cardiovascular Imaging came up with this consensus statement talking about the variation of parametric maps and how they can be used in the assessment of disease. And they talk about these four groups. Native T1 relaxation time, which we've already looked at in relation to our patient with Fabry's disease, which is shown here as diffusely low. But interestingly, we can see here T1 will be elevated in myocarditis, it's elevated in amyloid, extremely low in iron deposition, and intermediately elevated in diffuse fibrosis. We can also assess extracellular volume. If we do further T1 measurements after the administration of gadolinium, we can start making a calculation, because gadolinium is an extracellular contrast agent. By comparing the pre and post contrast images, we can generate these maps to try and estimate extracellular volume and get direct measurements. And again, you'll see this varies depending on the disease states. T2 weighted imaging is another physical parameter of hydrogen atoms as they spin within the magnet, but they're very susceptible to myocardial water, and this is a hugely sensitive technique for looking for myocardial edema, and therefore T2 times are hugely elevated in examples of myocarditis, and I'll show you an example of that later. T2 star, another physical parameter, but we know that this is significantly shortened and reduced if there's any evidence of iron deposition, particularly in patients who've had who have hemochromatosis, or those patients who have regular blood transfusions for chronic anemias. And you can see here diffusely low parametric T2 start times in a patient with iron deposition. So this is a whole suite of techniques that we have now available that is really very good for helping us understand what's going on within the tissue characterization of patients with myocardial disease. This is just another graph from that paper showing the sort of different pathologies you might see and how they vary depending on the native T1 time and the extracellular volume. You can see our patient here with Fabry's disease, in addition to having very low native T1, they also have a very low extracellular volume. How about guidelines? What do we have to indicate how we should be using CMR in these patients? Well, the American College of Cardiology came up with these guidelines in 2019. And I show you here on this table here, which is basically looking at the initial assessment of patients, that actually there's relatively little indication for CMR as the first investigation of choice. And as you might all expect, echocardiography is indeed the investigation of choice. However, if we look at the next table, table 3, looking at sequential or follow-up testing to clarify the initial diagnosis, you can see that aside from the investigation of electronic devices inserted, that CMR has really very good indications for all the variety of different pathologies and ventricular dysfunction that they describe. I just want to touch specifically now on myocardial inflammation. Again, with another case. This is a 79-year-old woman who was COVID PCR positive, and she presented with troponin rise and dynamic ECG changes. She had mild left ventricular dysfunction on her echocardiogram, and cardiology were not convinced of an acute coronary syndrome, so asked us to perform a cardiac MRI in the first instance, and I'll show you her pictures now. You can see here, up in the left panels here, she does have a degree of myocardial dysfunction, although not severe. There's certainly no significant focal wall motion abnormality. Her late gadolinium enhanced sequences show here that she's got a small rim of pericardial effusion, but importantly, if we look at her myocardium, there is no significant late gadolinium enhancement, perhaps just a suggestion of some minor circumferential subepicardial increase signal here. But when we go to look at her parametric maps, we can see here that her T1 map showed diffuse elevation of a T1 relaxation time. I should note at this point that there are no standardized values for elevated T1 and T2 relaxation time. It's very much dependent on the field strength of the magnet you're using and the specific vendor that you're using. And most centers have to do some internal validation with their physics team to work out what the normal range of T1 and T2 relaxation times are. For our scanner, normal range is normally between 950 and 1050 milliseconds for T1. So clearly 1200 is very elevated. And for T2 maps, anything over 50 milliseconds is clearly elevated, and we've got 67 milliseconds, which would tell me here that there is diffuse myocardial edema throughout the heart, and this was a case of acute myocarditis thought to be secondary to her COVID infection. There have been some recommendations on the evaluation of myocardial edema that have been published recently, back in 2018 in JACC by this expert panel, and they've come up with specific criteria for the identification of myocardial edema and non-ischemic myocardial injury, as they describe the 2018 Lake Louise criteria. And what they're asking you to look for is either regional or global increase of native T2 relaxation time, or a generalized increase in T2 signal intensity on these black blood sequences. I haven't shown you any of these because in our institution we've moved almost exclusively to use mapping techniques for the evaluation of myocardial edema. For the assessment of non-ischemic myocardial injury, they're looking for elevation of T1 relaxation time, as I've shown you, or a subtle increase in late gadolinium enhancement, or an elevation of the extracellular volume. They do also go on to note that supportive criteria for looking for these sort of injuries is looking for any evidence of pericarditis, such as effusions or pericardial thickening, and we saw a small effusion in our case, and indeed systolic left ventricular dysfunction with impairment of function. While we're talking about COVID, I thought, and it's hard not to give a talk in the current climate without some sort of mention of it, I thought there are many papers that have been published on the concerns over COVID myocarditis and the impact on the heart of COVID infection. But this was a really interesting paper that was published in JAMA Cardiology in 2020 by Valentina Puntland, where they looked at patients who had confirmed COVID infection, either recovering at home or recovering within the hospital. but no evidence of myocardial disease. So these are patients who had upper respiratory tract infections or lower respiratory tract infections, but no clinical evidence of myocarditis. They were invited for cardiac MRI for the evaluation of any myocardial damage. And what I can show you here is clearly there was elevation of high-sensitivity troponins in those patients who recovered at home or were hospitalized in compared to age-matched controls, either healthy controls or other patients within the hospital. But interestingly, we saw exactly the same parameters when we were looking at native T1 and T2 relaxation time. In fact, the T1 and T2 relaxation times were more sensitive to myocardial damage in these populations than the high-sensitivity troponin, as you can see here, evidenced by the area under the curve compared to the risk factor matched controls. So this is showing really very interesting data that in anyone who has COVID-19 infection, there is a risk that they have some evidence of myocardial injury, even if that is asymptomatic. And I think in this study, they found 78% of the 100 patients that they studied had some evidence of cardiac involvement, and 60% of them had evidence of ongoing inflammation. I understand the mean time between diagnosis of COVID and scanning was about 67 days in this patient. So a really interesting study showing the benefit of these very sensitive techniques for looking at changes in myocardial architecture. So finally, I just want to touch on what is the role of MRI in congenital heart disease. Clearly, it's not possible to talk about the whole of congenital heart disease, but as in a basic principles, the benefits that MR offers us with the ability to evaluate not only anatomy and chamber function size, but we can also assess flow. And that allows us to look at shunt calculations. So we've got an example here of a cine image of a patient that shows clear right ventricular dilatation with a very aneurysmal interatrial septum, and you would be concerned, although we can't see it directly, that there may well be some evidence of an atrial septal defect here, which is driving a left to right shunt, which is responsible for the enlargement in the right ventricle. Well, we can go on and measure the right ventricle using our normal techniques of contouring the ventricle all the way through. And in this particular instance, if I show you the figures here, you can see here that this patient had an end diastolic volume of 178.7 mils per meter squared. This is indexed for the body surface area. Well, the normal range for patients is between 48 and 87. So this is a severely dilated right ventricle, which we assess with our visual assessment. We're now able to quantify that. We're then able to go on in this individual and actually assess their blood flow within their ascending aorta and also within their pulmonary trunk, and absolutely quantify it. And you can see here in this particular case that the MR has told us that per heartbeat there's approximately 54 mils of blood passing into the ascending aorta. When you compare that to the amount of blood that is actually passing into the pulmonary trunk, we've got a pulmonary blood flow of 143 mils per meter squared, which then looking at a QP-QS ratio, that gives us a shunt of 2.6 to 1, so a not insignificant shunt, indeed very large shunt, which is the reason why this patient has developed chronic right ventricular dilatation over time. The other huge advantage with congenital imaging is because MR is truly multiplanar, because it's been driven by the radiographer at the time of the scanning, is we can start to plan our imaging plane in any plane we wish. And in this particular instance, in this quite old paper put in circulation now, it shows beautifully that if you place your flow acquisition plane in the correct plane, you really can get a very good idea of the size and location of any atrial septal defect, or indeed any shunt within the myocardium. One area which has seen huge growth over the last few years because of increasing computing power and scanner technology is that of 4D flow, not something that we have available to us clinically at the moment at our institution, but we're working on it. And this is a technique where rather than just doing targeted flow assessment, just looking at the aorta or pulmonary artery or individual branch pulmonary arteries, you can take a volume through the myocardium and the blood vessels, and it takes some time to acquire, but actually at the end of it you will have a whole volume of not only you have flow data over time, which you can then process and work out absolute blood flow through the aorta, through the pulmonary trunk, and through indeed any particular shunt. And I think this is something that we will see being used more and more as the acquisition times come down. As far as indications and guidelines for the use of congenital heart disease, well, there are many to comment on. These are just three examples of the position statement of the Journal of the Society of Cardiovascular MR, the ESC, and the American Heart Association, all showing that actually CMR is clearly indicated for specific indications and particularly for quantification of myocardial blood flow and the assessment of right ventricular volumes. So in summary, I really just want to say CMR has a huge and diverse role for patients with cardiac disease. It truly is multi-parametric, with us developing new tools all the time, which are bringing new clinical applications, and as a consequence we're seeing the guidelines rapidly evolve on the basis of this. So it really is a very exciting field to work in. There's a huge research area, and I'm pretty sure that as I work another 10 years in this practice, the job that I'm doing today will be very different to what it will be in 10 years' time as these techniques evolve. Thank you very much for the invitation to talk and listen to me, and I'll be more than happy to take any questions. Thank you.
Thank you, Professor James, for your elegant lecture on cardiac MRI. In fact, you gave a good description and interpretation of cardiac MRI. So once again, I take this opportunity to extend our gratitude on behalf of Sri Lankan College of Cardiology. So thank you very much, Professor James. Now is open for panel discussion.
Yeah, we have time for questions. I'm sure the speakers are online. Yeah.
Excuse me, may I ask a question? Professor Russell from UK, and it was an excellent lecture on the CT, cardiac CT imaging and how to perform an imaging. Hello, can you hear me? Professor Russell, I just want to ask, right in the beginning, you were mentioning about high-risk CT plaque identification on a non-high-risk angiographic lesion. Will this be dependent on plaque characteristics mainly, or is it because of the reporter's experience, or on the cardiac CT performing machine abilities? Which one out of these is most important, and how do you enhance the identification of these high-risk plaques?
Could those of you on the repeat the question actually on the chair here? I think the question was, what's the most important? Is it the machine or is it the individual's reporting? Was that right?
Yeah, individual reporting, or is it the plaque characteristics or the machine, which gives you the maximum identification of high-risk plaques on these pictures compared to the coronary angiogram, which is labeled as non-significant?
Yeah, well, at the moment, you need a good image, so you do need a good machine. But once you've got a good image, it's high-risk plaque features, his face. It's not so difficult. As long as you've got an experienced reporter, you basically identify that the plaque is low density, or it's got spotty calcification, or it's got surrounding inflammation. That some of that work will be done by AI in the future, but it's done by a reporter at the moment. But you do need to get a good image to see that. But there's a lot of data now. It's quite amongst experienced reporters. It is quite standardized, and basically, the more high-risk plaque you have, the worse your risk is. It seems to be that it's a high-risk plaque. It seems to be that it's the stenosis that gives you angina, but it's the high-risk plaque that kills you.
Oh, thank you, Professor Russell.
I would like to ask another question. Actually, when there's a moderate lesion on CT coronary angiogram, and whether you would prefer to do a CT FFR or cardiac MR with perfusion, which test you believe more, and what is the test you use more frequently to detect whether it's a flow-limiting lesion, whether you use a CMR with perfusion or CT-FFR?
Do you want to take that one, James?
Yeah, happy to.
I think a lot of it will depend on the other information. I think if it's first onset of a patient who's got chest pain and a normal left ventricular function on echo, I think the use of CT-FLFR in that instance is an excellent way of evaluating the severity of stenosis, because you don't need to do another test on the patient, and it will give you an indication of whether it thinks that moderate lesion is ischemic or not. I think, however, if a patient was known to have coronary artery disease and has some evidence of left ventricular dysfunction with focal wall motion abnormality, I think there is an advantage in performing an MR to investigate further, because in addition to doing stress perfusion sequences to see if it's significant, you'll also get some understanding of whether there's underlying scar, because the bottom line is if there's an infarct there which is non-viable, it's irrelevant whether there's a significant stenosis, because you're unlikely to want to revascularize it. So I think it depends on the other features for me. If it's a normal patient, new onset chest pain with normal left ventricular function, I think CT-FLFR works very well because it doesn't need to bring the patient back for another test.
James, I have one more question. Now, you mentioned about the T2 and the T2 star findings on post-COVID patients, and how long these last, and can they be reversible and maybe completely disappeared or not in these MRI scans?
I don't know. I haven't seen the data on whether these will completely resolve. My anticipation from experience with other episodes of myocarditis, then yes, you would expect that the myocardial edema, certainly the T2, will resolve over time. There's no doubt that there will be a small number of patients that fall into a kind of chronic myocarditis state, which then go on to develop some evidence of subepicardial scarring, and a pattern, we see that pattern on late gadolinium enhanced sequences, and you might imagine in those circumstances that you might be left with some persistent elevation of T1 relaxation time. But I would envisage that you would see a complete resolution of edema at some point, although as to how long that is, I don't know.
Yeah.
Patients that you had this post-COVID, how long they have been after the COVID?
Inevitably, yes. You will have more edema closer to the acute infection, which will settle down. The paper that I showed you there was 67 days, so that was still 2 months. And these were patients who'd had COVID infection but did not have clinical myocarditis. So, but yes, you would expect the edema to settle down. Russell, I think you said you wanted to just add something.
If I were just to emphasise what you said, it seems that the data's coming out is that COVID myocarditis seems to be different from most myocarditis. It does seem to often last longer, and that's been some of our experience. It is pretty unusual to see elevated T2. I'm sure you'll agree, James, that several months after acute episode, but you do see that with COVID. So it is, like many things, COVID seems to be a strange disease that seems to cause chronic myocarditis relatively commonly, it seems.
Can I ask one question? Is there any place for cardiac CT or CMR for assessing acute coronary syndromes like non-STEMI or post-STEMI?
Do you want to go first, Russell?
Yes, there was a. Is there a role? Yes. Is there a routine? Should it be your first line? I think definitely not. I mean, certainly our NICE guidelines are that you should not do CT first line in a suspected ACS. That you still catheter angiography is the first line. Now there will be exceptions to that if a patient comes in, they're 30 years old, they've got no coronary risk factors, and the clinicians think it's far more likely to be myocarditis than ACS, then you may do CT first line. But certainly if you think if you've got a 75-year-old diabetic smoker that comes in with ST elevation, you should not waste time, I think, doing a CT. I think that's unwise. There was a study done in the UK called Rapid CTCA that looked at cost utilisation of acute CT for suspected ACS, and actually the conclusion was that it was not recommended. The data didn't shake out that it was of benefit to the conventional pathway. So certainly personally, in a suspected ACS, if you think it really is suspected ACS, I don't think you want to be doing a CT scan.
And I just entirely agree with Russell. From the side of MRI, clearly all patients who come in with ST elevation infarct go straight to the cath lab. Very rarely do we see patients who
come in having had thrombolysis for ST elevation MI, particularly if the Isle of Wight's very close to us here, and so where they don't have primary PCI as an option, well, they'll be thrombolized, and occasionally after that they'll be transferred to us in Southampton within the hours or the next day or so. And in those circumstances, we have sometimes been asked to do a stress perfusion MR just to understand the degree of myocardial damage and potential perfusion defects, to see whether there is benefit of taking the patient to the cath lab a number of hours, if not days later. Because if you can demonstrate such extensive infarction and no other perfusion defect, then they tend not to take them to the cath lab. Although there is a risk there that you can misinterpret myocardial edema in viable myocardium, but we do sometimes use it in those circumstances if there's been a delay to presentation.
Actually, I would say one thing we have found, because we do a lot of, like Southampton, like James, we do a lot of acute MRI in patients with troponin rises, and we have found that actually ACS is actually quite often misdiagnosed, and the patient actually has acute myocarditis or some other disease. So it seems it's quite easy to mislabel someone as having an ACS, and then in fact their coronaries turn out to be fine and it was myocarditis. We've sort of learned that because we do so much acute MRI. So there is a role, but it's just not first line if you're thinking of putting a stent in, because you don't want to delay the patient getting to the lab.
So you can sometimes see that the other way around as well, in a patient who does go to the lab and has normal coronaries, and then you do the MRI scan and you can either find the myocarditis, or in fact there was perhaps a tiny embolic infarct because the patient has a left atrial thrombus or something like that, which wasn't appreciated on the angiogram. So I think there is a role for MR and imaging of acute chest pain in that context, but not as the first line investigation.
Thank you, Professor James and Professor Russell, for your elaborative lectures and discussion. In the interest of time, we have to conclude this. Again, we thank, on behalf of Sri Lanka College of Cardiology, both of you for your excellent lecture and discussion. Thank you very much for your participation.
Thank you.